Okay, our apologies to anyone who's joining us a little bit late. So we just finished looking at a nodule in the dermis of bland fibroblasts with extravasation of red cells. And it happened to sit right adjacent to striated muscle, which was a clue that it was fascial in location. So nodular fasciitis, nodule, bland fibroblasts, red cell extravasation. Not that one. Okay, this one's good though. Okay, James.
Yes, sir.
How old or young is this person?
Old.
Judging by?
The solar elastosis.
Judging by the solar elastosis. Okay. What else do you see?
So, there's a really deep, what looks like a pretty robust inflammatory process, pretty much spearing the whole dermis, very deep in the dermis.
Okay, so at scan, what kind of cells do you have on the outside?
Like lymphocytes and histiocytes.
See those multinucleated giant cells?
Yes, multinucleated giant cells.
Tells you that it's granulomatous. Here, we can go one higher on those. But so multinucleated giant cells, they even form a little Teuton type giant cells there. So this is palisading granuloma. And what's in the center of the palisading granuloma?
Like a neutrophilic abscess.
Like a neutrophilic abscess. So palisading granuloma with neutrophilic abscess in the center, what's your differential?
Well, I think this is incorrect when I'm about to state, but like deep granulomatous process like that makes you think of a rheumatoid nodule, but those should not have.
You are absolutely
neutrophils
correct
in the
that
middle.
that should not have the neutrophils in the middle. Actually, you usually have just a little smattering of neutrophilic dust on the fibrin, which is in the middle. But here, what you have is just pus in the middle of a palisaded granuloma. So, anyone want to jump in with a differential? So, on the vasculitic side, Wegener's absolutely would be top of your list. Palisaded granulomas, multinucleated giant cell, pus in the middle, Wegener's could look absolutely identical to this. And then, Ashley, you were?
Plaques.
So
that's
this is a
plaques.
stellate abscess. So sporotrichoid granuloma is palisaded granuloma, newts in the middle. And so stellate abscess, mnemonic CLATS, and CLATS stands for?
Cat scratch.
Cat scratch.
LVG.
LGV.
Atypical mycobacterium, tularemia, and I think sporotrichoid.
And sporo.
Porokeratosis, yeah.
So CLATS, the stellate abscess differential was named for Stella Hoffman, our VD tech, who took it as an honor to become a mnemonic. Stella was our VD tech for years, and she was far too nice to have the clap, so she had the CLATS according to the resident, which was cat scratch, LGV, atypical mycobacteria, tularemia, sporo. Just gives you a handy little mnemonic for stellate abscess on the infectious side, and then you just have to remember Wegener's on the vasculitic side. So that's your differential. Very good. Okay, Rob.
Looks like we got a well circumscribed dermal nodule.
Yep, look at it up on the screen. I think it's even easier up on the screen.
It's darker.
What color is the nodule?
So it's like dark bluish purple.
Blue, right? So it's a blue nodule. And then what are all the red round things? Probably ducts, right?
Okay.
So what is blue with red ducts?
It's not. I was gonna say Palisaded, but it's not.
No ducts in pilomatricoma, although they are blue. Anyone want to jump in? Sebaceous tumors. So blue with red ducts. So red nodule with ducts is an acrosporoma. Blue nodule with ducts, sebaceous. Red with ducts, acrosporoma. Blue with ducts, sebaceous. So this is a blue nodule with red ducts. So you know it's sebaceous. And now the question is just, okay, sebaceous what? Adenoma, epithelioma, carcinoma. So looking at it, do you have, how well differentiated does this look? Do you see a lot of sebaceous differentiation?
No.
And when you look up on the screen, are there a lot of nuclei?
Yes.
And are some of the nuclei darker and bigger than other nuclei?
Yes. So maybe sebaceous carcinoma.
Yeah, I think you are correct from scan. Okay, so it's hypercellular. You see areas of impending necrosis, which a benign tumor usually wouldn't do. So it's blue with red ducts. You know it's sebaceous. It's got too many nuclei, or some of the residents have phrased it nicely, too damn many nuclei, right? So too many nuclei it tells you it's bad, right? And the nuclei are varying sizes, and some of them are dark and some of them are big. So tells you sebaceous carcinoma at scan. Very good. Which is the power where you always want to make the diagnosis. Okay.
So you have a dermal nodule with,
Yep.
that's not really well circumscribed, mostly basaloid with some cystic structures.
Cystic structures. Very good.
Some of the areas have the spectacle look like a trigoadenoma, but
And when you look at the stroma, is it myxoid or is it concentric fibroblast rich?
I think that it's fibroblast rich, concentric. I don't
I'd
know.
say this is one of those rare cases where it's not the second choice. The concentric fibroblast rich, they really are concentric. They're all going in the same direction, around and around. Here, I mean, that's pretty gray, amphiphilic, like in here, suggests that there's some mucin in there, which is not usually what the benign tumors have other than basaloid follicular hamartoma. And when you look at the color, can you make out the strands are kind of pink, and then the buds are blue?
Yeah.
So what has pink strands, blue buds, and horn cysts?
Like a microcystic, MAC. Basal cell.
So Max can do that, but a type of basal cell, anyone want to jump in?
Cystic.
Infundibulocystic BCC. That's absolutely correct. So pink strands, blue buds, horn cysts is infundibulocystic BCC, and here it's just grown up to adenoid BCC. So nodule of adenoid BCC, pink strands, blue buds of infundibulocystic BCC, pink strands, blue buds, horn cysts. Remember, uncommon variants or less common variants of very common things tend to be good discriminators. So a superficial multifocal BCC probably everyone would nail. But the less common variants of things that are very common and you see every day in practice are very much worth knowing. So pink strands, blue buds, horn cysts, infundibulocystic BCC. may be able to do this. So, Brian, there is fibrosis here. There are thrombi in the vessels. So if you just look at it, things that have lots of thrombi in the vessels, you're into coagulopathic disorders. But if you look in the sub-Q fat here, what's this blue chunky stuff?
So is it some type of embolus from elsewhere?
Yeah, more calcium, that kind of, and it's around every little blood vessel. So there's blue chunky stuff around every last little capillary in the fat. So what would be coagulopathic and have calcium around every last little capillary in the fat?
Possibly like a malignancy-driven process.
So, well, it can be associated with malignancy, and coagulopathic certainly can be, but anyone want to jump in? Calciphylaxis.
Okay.
So calciphylaxis, the idea is you suddenly calcify every last little vessel in the fat. You get stellate areas of necrosis, hard areas on the abdomen and thighs that develop retiform purpura. So hard indurated retiform purpura on the thigh or abdomen, often a diabetic or someone with very rapid weight loss. And it is both coagulopathic and the calcium. So the two ways treatment has been addressed is with TPA for the thrombi and with things like thiosulfate to dissolve the calcium. Get the blood flowing again.
So we have a really thickened stratum corneum. It's mostly orthokeratotic. Looks like maybe this could be like the roof of a blister, perhaps.
Yeah, so you definitely have a big orthokeratotic horn sitting on top of something. And then is there something that's sitting on top of normal or abnormal?
Abnormal. It's like a lot of necrosis in. Or all the cells are like coming apart, maybe some acantholysis.
So they're acantholytic, and then is it normal for cells to have red rings like that around the nuclei?
Not really. No, maybe not when they're dying.
So what would you...
They're
Are they keratinizing normally, or are they keratinizing in an abnormal,
we can go with abnormal.
dyskeratinizing fashion?
The second.
So you've got acantholysis and dyskeratosis.
So like a Haley-Haley's.
So it's absolutely a Haley-Haley pattern, right, where you have red rings around the nuclei. So that's very much a Haley-Haley pattern. The only thing that would be odd for Haley-Haley is the degree of hyperkeratosis, that you have a big cutaneous horn on top of it. Suggests that maybe it's a focal acantholytic dyskeratosis, acantholytic dyskeratoma. You know, it's an oma that would look kind of like a solitary lesion or tumor rather than being a generalized dermatosis. But it's absolutely Haley-Haley pattern of acantholytic dyskeratosis. Well done. Okay, so
trying to decide if this is the shave of a little kind of filiform papule, or
yeah, I mean either it's a shave of a papule that was kind of small and stuck up, and this is a horizontal cut, or it's a full thickness clip of a very thin patient, right? That's one of the two.
Like a CT scan?
Yeah.
I
So
think that's the spinal cord at the bottom of the screen.
more likely that this was a little bump and we're just kind of cut across. Okay, so I think you're good.
Okay. So I see a few dilated spaces that look like lined with endothelium, that look like blood vessels.
Yeah, so you got some blood vessels and you've got...
Some inflammatory infiltrate there with lymphocytes and a few larger cells.
And the few larger cells are kind of stellate.
Yeah, stellate, so they could be fibroblasts.
Yeah. So what's that leading you towards?
So there's not a whole lot of other, secondary adnexal structures in there. I mean, I thought about, depending on the body site, things like acquired digital fibrokeratoma. Or
So acquired digital fibrokeratoma, does it look like acral skin though?
No,
Not so
quite
much.
there. Mm-mm.
So you told me there was angio and fibro,
So like angiofibroma.
like an angiofibroma. But now let's go back to scan, and you got angiofibroma, all thrown in the same bottle.
Mm-hmm.
So I'm guessing the patient has more than one.
Most likely, yes. So I guess depending on the site, you call this angiofibroma, pearly penile papules,
So they could be
tuberous sclerosis,
pearly
like
penile papules, adenoma sebaceum of tuberous sclerosis. What else gives you multiple angiofibromas? You can see it in Birt-Hogg-Dubé, along with the fibrofolliculomas,
Okay.
and you can see it in MEN1. That's the other big one.
Okay.
And this
Yeah.
patient was worked up and turned out to have MEN1.
Right. I was forgetting about that one. Yeah.
So, just remember, any solitary tumor is likely to be sporadic. Multiple tumors are often syndromal, and then the task is to identify the syndrome because it could have real health consequences for the patient. So a solitary trichomoma is just a trichomoma. You got a bunch of trichomomas, you probably have Gowton's. You have a single angiofibroma, it's just a fibrous papule. You have multiple angiofibromas, if they're on the penis, they're associated with nothing. If they're on the face, they can be associated with tuberous sclerosis, with Birt-Hogg-Dubé, with MEN1.
That looks familiar.
It does. So, at scan, what would you say?
Wigner's or Klatz.
Wigner's or Klatz. Very good. And what does Klatz stand for?
Cat scratch, LGB, atypical microbacterial tularemia spora.
Very good. Okay, but that wasn't your slide. This is your slide. Okay, so that's the surface skin. And then this is all the deep change.
In the center there, it just looks like a lymphatic vessel.
Yeah, and it's filled with lymph, right? It's not blood, it's lymph. So you got all of these big vessels filled with lymph. So what is this?
It's just a larger lymphatic malformation.
Yeah, lymphatic malformation, cystic hygroma, cavernous lymphangioma. It's all the same thing. Yep. Well done. That's exactly what it is.
Alright, so for this you have a bit of a cup-shaped invagination with the hyperkeratosis. There's central hypergranulosis as well.
Yep.
So we could be cutting into the edge of a KA.
So that would be the concern, is the possibility that you're cutting into the edge of a keratoacanthoma. Or what else would be the other most likely?
It could also be a wart,
Yeah.
because we're on plantar skin.
Hyperkeratosis, acanthosis, papillomatosis. The hypergranulosis is in the dells. There are tears around perikeratosis coming above. So wart would be the default diagnosis, except that each of these is follicular, and there's a little bit of probably an acantholytic AK there, so then you really do worry this might be the edge of a keratoacanthoma, and you'd have to see how it behaves. Okay, Cheng. First off, where do you think you are?
It's cartilage.
Cartilage and...
Sebaceous focal. It's maybe an ear.
yeah, it's probably an ear. That's probably... we're up in Pinna here.
Serious.
And so what's going on this ear?
Oh, it's a very big melanocytic nodular.
Okay, so from scan, are you thinking this is a good thing for the patient? Or a bad thing for the patient?
I think it's too big.
I agree. I agree 100%. So you have this big spindle cell thing producing tons of melanin sitting on someone's old ear, and we're going to look a little higher at the cytology here. And they certainly have visible nucleoli. Many have multiple nucleoli. And in some of them, you're starting to get this strandy chromatin pattern. So this is a really good example. Let's pull that guy to the middle. See how you've got all these tiny little chromocenters connected by strands? It's very irregular. And when you look around, a lot of the nuclei have that pattern of chromatin. After the session, Google images for the pepper moth. The wings of a pepper moth look just like that. So that's a pepper moth chromatin pattern which goes with melanoma. So this is a big, ugly melanoma. Okay, Adam.
Okay. Just processing here in a second. So you got a little collection of a papule in the center with lots of little dilated blood vessel spaces.
Okay. And are the walls all the same thickness?
No.
You got thick ones and thin ones?
Mm-hmm.
What is it?
So an AVM.
AVM, absolutely. So you have thick little feeding arteriole, and then proliferation of little thin-walled vessels is an AVM. Very good. Okay.
It looks very stubby, just because the horn pseudocyst and the...
So it looks very sebby.
But I'm trying to figure out what the pigment is.
Yeah, probably melanin with nests. So lesson 1 is the presence of horn cysts on when you look with the dermatoscope does not make something a seb.
Yeah.
It doesn't rule out anything melanocytic. So, horn cysts are very common in melanocytic lesions, and so presence of horn cyst, or people used to take liquid nitrogen and lightly frost it, and you can see the horn cyst. Doesn't mean it's not melanocytic. So that's lesson 1. Okay, lesson 2. What is it? So first question is, at the edge, Does it seem to end in a nest?
Yeah, I mean, yeah, that's what you're pointing
Yeah.
to. It's hard for me to
So-
tell the edge because it looks like it's folded back.
Yeah,
on
it's
itself.
kind of an oblique cut, but does appear to end in a nest, be well circumscribed. There's a little bit in the arches, but not much. Most of it is tips and sides of reedy. The nests are pretty round. The one thing that's freaky about them is
They're large, yeah.
they're large, and are the cells holding together, or is there white
No.
space around all the cells?
Yeah, so they're definitely falling apart.
So they're kind of falling apart, poorly cohesive. So what would be a small, well-circumscribed melanocytic lesion composed of big nests that are poorly cohesive? Anyone want to jump in?
Special site?
Yeah, those are the special site nevi.
Mm.
The ones you get on ear, scalp, breast, genitalia, Macarena sites. Some people have said any site you can pierce has this pattern of nevus. So whatever helps you remember the sites that get it. But you see them in flexures too. I haven't seen a lot of pierced flexures. Earlobes certainly fit that way of remembering it. But they're any of the Macarena sites can have the special site nevi, and they look funny.
Yeah.
So the problem is, because they look funny, the pathologist often says looks horrible, cut it out. Okay, so you've just been told to cut it out, and where is it? It's on the ear, it's on the nipple, it's in someone's genitalia. People tend to be protective of those sites, and doing big excisions. This would be a typical 12-year-old kid, and the lesion itself, you took it off because it was 1.2 centimeters. Now you're going to go back with a margin in a kid's scalp. These are big excisions for completely benign lesions, totally benign lesions. So important to recognize for that reason. So reasonably small, well circumscribed. The only problem is the nests are big and they're poorly cohesive. But that's completely normal for site in any of the special site nevi. Okay. James. Uh-huh.
So, I don't know. One of the things to say about this. It seems like we have this hyperkeratotic lesion where it's all kind of falling apart, falling off.
Yeah, so hyperkeratotic, and the hyperkeratotic part is kind of falling out of it, right?
Mm-hmm.
And what's the overall configuration?
It's somewhat of like a cup shape, invaginated a little bit. Maybe.
Cup shape, invaginated, scalloped, filled with keratin. Sounds like you're describing what kind of thing?
I don't know, I'm sure you're going to have some name that's like a combination of like, it's an invaginated keratoma. Classic.
No, actually, but I appreciate the.
I mean, I don't think it's an IFK, which means like it's like a cup-shaped, semi-keratotic thing, but it's
No, IFKs are more like a finger that
Right.
protrudes downwards.
Yeah.
So, anyone want to jump in?
Terminal KA?
Yeah, involuting keratoacanthoma.
Oh.
So an acanthoma, a keratoacanthoma that's growing, has big glassy epithelium, and a KA that is involuting. You see all the keratin. It's cup-shaped, invaginated, scalloped, but the epithelium has gone skinny.
Yeah, that makes sense.
Okay, so regressing KA. Also known as the inverted scallopcopoma of LeGroux. Okay. Big or small? It's not a trick question.
Very large.
Very large. So, you know, by the largeness, you're thinking probably good or probably bad?
Probably bad.
Probably bad. And then we're going to look a little higher at the largeness, and you're going to tell me the type of differentiation we have here.
Is it lymphatic?
So I'd say it's probably an epithelial proliferation. And then what kind of differentiation do you see there at the... Anyone want to jump in? Sebaceous. Yeah, you got a scallop, dark nucleus, and all of those little droplets in the cell that are lipid droplets. So it's probably sebaceous,
Sebaceous cell carcinoma.
like another sebaceous carcinoma. So at scan, it's blue. You don't see a lot of ducts in this one.
That's what I was looking for. I didn't see it.
So blue with ducts tells you it's sebaceous. Blue without ducts could mean that it's sebaceous, but so poorly differentiated that it's not forming ducts anymore. Okay, so this gives you, you know, a little bit of the spectrum of sebaceous carcinoma.
Looks like a biopsy.
Very small. Shaved biopsy, very atrophic epidermis.
So a shaved biopsy, atrophic epidermis, very good.
Looks like there's some beginnings of hair follicles, but it's hard to see that. Not much in the way of like a lichenoid infiltrate, like you would think about LSNA or radiation dermatitis with that type of atrophy.
Okay, very good.
Sometimes.
Kind of hard. I think this one's pretty hard.
Okay.
Because this is the...
Oh, is that like a cornoid?
That's like a
lamella?
cornoid lamella.
Oh, man.
Yeah.
That's
Pretty
tricky.
tough.
So that was a pretty wimpy cornoid lamella in that cut. So you did well. Let's see.
So, just from scanning power, got a large, kind of atypical, or acanthonic area with central area of, looks to be necrosis.
Agree. Compare these cells to these cells. Which cells would you rather have?
I'd probably choose the second choice.
Probably the ones that are not overtly malignant. So, you know, large, hyperchromatic, very pleomorphic, Mercedes-Benz type of mitoses that are tripolar, atypical mitotic figures. So highly malignant population centrally.
Mm-hmm.
And the highly malignant population appears to be coming off of the benign epithelium, has lots of pink, suggesting it's keratinizing.
Mm-hmm.
So, what do you think?
Just a very, very poorly differentiated squame.
Yeah, poorly differentiated squamous. Actually, if it's making any keratin at all, it still falls into moderately. So well differentiated are glassy red, like a Ka. poorly differentiated, is spindled or anaplastic, making no keratin. The only way you know it's a squame is immunostaining. And everything in between is moderate. And the reason their moderate has that big spectrum is it does define behavior. Well differentiated behave in one way. Poorly differentiated behave in another way. And that whole spectrum of moderate, doesn't matter where you are in the spectrum, the behavior is pretty much the same for that whole moderate group. They have some competence for metastasis, but not much. Certainly locally aggressive tumors. Okay. How about this one?
So it's dermal nodules, pretty well encapsulated.
And what color would you say?
It's kind of blue.
Kind of blue. Kind of blue with very pale areas, right?
Mhm.
So it's a nodule that's very blue with pale areas.
So thinking like a sebaceous process.
Like a sebaceous process. I don't see red ducts, so it's certainly not a well-differentiated sebaceous process. And if we look higher, I do see sebacites there. I also see lots of mitoses and high nuclear cytoplasmic ratio and very large cells in the blue area and atypical mitoses. Sorry, we lost our signal there. There we go. Apologies to those online. So what would be a poorly differentiated sebaceous nodule with lots of mitoses and high nuclear cytoplasmic ratio?
So sebaceous carcinoma.
Another sebaceous carcinoma. So again, we're hitting, a lot of these are composed to give you review or let you see spectrum of disease.
I have a question.
Yes.
For sebaceoma, how many mites do you allow? Because I've seen sebaciomas with quite a few mites.
Yeah. So sebaciomas can have mitoses. They usually no atypical mitoses. The nuclear cytoplasmic ratio usually isn't bad. The cells aren't terribly large. It remains a nodule, and it has very well-defined red ducts,
So
telling you that it's still reasonably well-differentiated.
Okay. So not as much mites.
Not as many, certainly no atypical,
Yeah.
less atypia, usually no necrosis, a well-defined nodule, and very well-defined red ducts always in the sebaceoma.
Okay. Thank you.
Whereas the sebaceous carcinomas can have red ducts, but many of them don't, because they're not that well differentiated.
Alright, so we have a kind of superficial dermal nodule here abutting the
Superficial
epidermis.
dermal nodule abutting the epidermis. Very good description.
It's
Let's see what the nodule is composed of.
question here. This looks like you have two populations of cells here, some with larger cytoplasmic volume and then some smaller cells, and then
And those with larger cytoplasmic volume, vesicular nuclei, prominent nucleoli are probably what?
Plasma cell.
Or the big thing, probably a histiocyte.
Oh yeah, okay, yeah.
Okay, so these are probably big histiocytic population. And then you've got, what other kind of cell types do you have in here?
Oh, you see some eosinophilic.
Lots of
nuclei.
eosinophils, right?
Mhm.
So histiocytic population, lots of eos. So that makes you think of things like what?
Yes. I mean,
Xanthogranulomas and Langerhans cell histiocytosis are the spectrum that have the eos with the histiocytes. So you'd think of, something in the xanthogranuloma spectrum, you'd think of LCH, so you'd probably get a CD1A. But there's another hint here. There's so many nuclei sitting within the histiocyte cytoplasm. And are any of them pycnotic? Or are they all nice and gray instead of black?
gray.
So they're all still viable. So they're not being engulfed or phagocytosed by the histiocytes and killed. They're just passing through the cytoplasm,
Peripoiesis.
which we call emperipoiesis. So what histiocytic process has a polymorphous inflammatory infiltrate that tends to just wend its way through all that histiocytic cytoplasm? You are correct that it is called Rosai-Dorfman.
Yeah.
Okay, and you'd expect it to stain how? S100 positive, which is the same that LCH would stain. So with the EOs, that's really going to come down to your differential, and you're going to want a CD1A. But the emperipoiesis is a very, very strong indication that this is Rosai-Dorfman and not Langerhans cell histiocytosis. Okay. Very good. Okay. So, Katie, what do you see here?
Looks granulomatous to me around the vessels.
So it looks granulomatous, and so if you see granulomas, and you said around the vessels, so if you have granulomas that are horizontally oriented parallel to the surface and follow the neurovascular bundle, what are you thinking? What are you describing?
I mean, you have to rule out leprosy.
Leprosy, absolutely. And leprosy, there was presented at the DMEDEX meeting that we had here, data from Central Florida, massive spike around Orlando of leprosy diagnosed. Made all the papers, CDC's involved, and the point that the dermatopathologist who is reporting it is making is that this is not a spike in incidence, this is a spike in recognition. These people have been out there, this incidence is out there, it's tuberculoid disease, it's getting called sarcoid, it's being mistreated, and it's common. It's just being missed. So granulomas, horizontal, parallel to the surface, following neurovascular bundle, think leprosy. Okay, so we've done that, and then some of these, though, are rounder, higher up, not around neurovascular bundles. So what other granulomatous disease? So are these naked or are these dressed? And remember, I was taught dermapath by Southerners, so it's naked. Right, so are these naked or are these dressed granulomas?
I mean, they have some lymphocytes, but I feel like I'd still put them in the naked category because there's not really a robust infiltrator.
But you said they have lymphocytes.
Mm-hmm.
That makes them dressed.
Scantily clad.
Scantily clad, yes. Partially clad. But sarcoidal granulomas really shouldn't have the lymphs. If the lymphs are there, then it's not truly a naked granuloma. And these are partially dressed granulomas. So we better go down the differential of both naked granulomas and non-naked granulomas. So if we, because these are partially closed, so if we say the naked granuloma or naked granuloma differential, what's the differential for naked granulomas?
I mean, the big one obviously is sarcoidosis, but you also have to think about the, like borreliosis.
So sarcoid, zirconium, beryllium, what else is in there? If I got a puffy lower lip,
like Melkerson-Rosenthal.
Melkerson-Rosenthal, chylitis granulomatosa. If I've Crohn's, absolutely. So if this were a woman or young girl with terminal ileitis and massive swelling of the labia, you would think cutaneous Crohn's. And if they are clothed granulomas, non-naked granulomas.
TB.
Yeah, now we're more on the infectious side. TB, leprosy. So you kind of have to think of both. And this is a patient with a long history of inflammatory bowel disease and happens to be cutaneous Crohn's, but you sort of have to work your way through the whole differential and then see what fits clinically. Keep an eye on the time. We are almost out of time. So, Ashley.
Okay, so that looks like another cornoid lamella.
Looks like another cornoid lamella. We got Poro. Okay, this is a better cornoid lamella. Remember, the center of Poro can look like anything. Can have epithelial atypia, can be psoriasiform, can be lichenoid, can be atrophic. Center of Poro, like anything. It's all about recognizing the cornoid lamella at the edge. Okay, Cheng.
Lymphatic proliferation around the D junction, and I have some superficial scar.
So melanocytic at the DE junction, and it's sitting on top of what appears to be a scar.
Maybe regression, lichenoid regression.
So maybe lichenoid regression of melanoma. What else could it be? Do you see any deeper melanocytic?
Maybe recurrent nevus.
Recurrent nevus. So you have nevus, then you have scar, then you have a confluent atypical junctional proliferation, recurrent nevus. Well done. Dr. Braun. Looks like a Keratoacanthoma. It has glassy epithelium. It is crater-like. It produces keratin. If this were to involute, what would it look like?
Then you got your
Carcinoma.
Exactly. So it would keep its crateriform architecture. It would keep the keratin. It would start to fall out, but it would go to skinny epithelium. Okay. And for the Ka, the presence of neutrophil microabscesses, elastic trapping at the periphery, eosinophils in the infiltrate are all clues that it's more likely to behave as a Ka than as a conventional squame. Gives you the options of injecting methotrexate, 5-fluorouracil as options to excision. And with that, we are right at the hour, so that's it. We will, as we get going in the year, we will get faster and faster, and by the end of the year, we usually hit 75 to 100 slides per hour. Right now, we're at about 25. But your pace will accelerate. The other thing is, you guys do have the resources here. Third years especially, you need to be doing a box a month. If you're not going through a box a month and reviewing them, you will not be ready for boards. And you need to do them pair up or do it in triplets. We got plenty of scopes. And quiz one another or quiz yourself. But a box a month. Second years, get started. And first years, it's a great way to start learning. I mean, it's all about volume and repetition and pattern recognition. We did that little exercise at the beginning of the year with the artists and the paintings. Even with no one sitting there pointing things out to you, your brain starts to recognize the patterns. By the end of having seen 40 Cajo paintings, you can pick out a Cajo painting just by the commonalities, the patterns that you pick up. And you can do the same running through them yourself, even without someone there teaching and pointing things out. So, okay.
Thank you, sir.
Thank you.
Thank you.